When administering a local anesthetic, it's important to make sure that your patient is lying in a supine position in order to reduce the likelihood of syncope. Patients about to receive an intraoral injection are often anxious, and if they're sitting upright, there's a chance they'll faint. Topical anesthetic may be placed prior to any injection. It should remove the initial sensation of needle penetration and therefore may be of value. If used, you should allow a few minutes for onset of action. The sensation of needle penetration is also reduced by the retraction of soft tissue such that the mucosa is taut. With all the mandibular techniques, it is preferable to use a 25 gauge long needle. The 25 gauge is preferable to the narrower gauges for two reasons. First, the aspiration results are most reliable with this gauge. Secondly, there is less deflection, an important characteristic for a deep block. Studies have shown that patients cannot differentiate among the 25, 27, or 30 gauge, so there is no advantage in using the narrower gauges. The primary goal of all of the mandibular blocks is anesthesia of the inferior alveolar nerve, which innervates the pulps of the mandibular teeth on that side, as well as the buccal periodontium anterior to the first molar. For each of the three techniques we'll describe, this goal is accomplished by depositing anesthetic within the pterygomandibular space. This space is bounded laterally by the ramus of the mandible, medially and inferiorly by the medial pterygoid muscle, superiorly by the lateral pterygoid muscle, posteriorly by the parotid gland, and anteriorly by the thin buccinator muscle. This anatomical space contains the inferior alveolar nerve as well as the lingual nerve, which is usually also anesthetized by these techniques. It also contains the inferior alveolar artery and vein and the sphenomandibular ligament. With all the techniques, it's best to begin by palpating the intraoral landmarks, which to an extent are similar. There are several reasons why mandibular blocks sometimes fail. Incorrect technique is one. Inflamed or infected tissue is another. You shouldn't administer anesthetic into areas of infection, as the acidity of the tissues may prevent onset of anesthesia. Patient apprehension is a third. When patients are anxious, they may interpret routine tactile sensation as pain. You can reduce patient anxiety by either non-pharmacologic or pharmacologic means. Another reason why mandibular blocks fail is intravascular injection. Injecting directly into a blood vessel can lead to a number of toxic events and will also take the local anesthetic away from its site of action. One last reason why mandibular blocks fail is anatomical variability and accessory innervation. In spite of correct technique, a variation in the normal anatomy may preclude successful anesthesia. For example, the flare of the ramus may be greater than normal, or the mandibular foramen may be positioned higher than usual. Accessory innervation may also be present. This may be the reason we sometimes find residual sensation even if all of the subjective signs of anesthesia, such as a numb lip, are present. Accessory innervation may originate from several sources. The inferior alveolar nerve may give off branches anywhere following its exit from foramen ovale. These accessory branches can enter the mandibular canal through any of the foramina on the medial aspect of the ramus, usually near the coronoid process. This particular route often innervates the second and third molars. Other sources are branches which travel with the nerve to mylohyoid, which often innervate the teeth anterior to the molars. It has been proposed that accessory innervation to the third molar may originate from a branch of the auriculotemporal nerve, which enters a foramen near the neck of the condyle. Branches may accompany the lingual or buccal nerves, and the routine blockade of these nerves should result in profound anesthesia. How is residual sensation due to accessory innervation treated? The key is to deposit local anesthetic such that it lies proximal to where the accessory branch rejoins the main trunk of the mandibular branch of the trigeminal nerve. This means that techniques which bring the anesthetic more superior or deeper should be more successful. This may be the explanation as to why the alternative techniques, namely the Gaugates or Akinosi, have been reported to have high success rates. On occasion, accessory innervation may also be anesthetized by administering the local anesthetic adjacent to the tooth. This may be accomplished by administration of either a paraperiosteal, a periodontal ligament, or an intraosseous type of injection.